Our first topic for today is atrial fibrillation. Atrial fibrillation, the presentation of atrial fibrillation is that the patient will present to you with palpitations. On examination, there will be irregular pulse, and on ECG, there will be no P waves and irregular QRS complexes. Let me show you an ECG as an example. This is an ECG of atrial fibrillation. Uh, these waves with high amplitudes are R waves or QRS complexes. Remember that normally on normal ECG, Q wave is not present. A normal ECG contain only two waves, R and S wave. The first positive wave is R wave, like here. This one is R wave, and the first negative wave is S wave. This one is an S wave. So anyhow, we'll call them QRS complexes. So you can see that in this ECG, this QRS complex is followed by the T wave, but after T wave, there is no P wave. You cannot appreciate the presence of P wave. So absent P wave. The first hint for atrial fibrillation is absent P waves on ECG. Similarly, you can see in this waveform here. Can everyone see the cursor?
Yes.
So see that after this T wave, there is no P wave. Similarly, after every T wave, after every QRS complex, there is T wave, but after T wave, you cannot see any P wave. So the first hint towards atrial fibrillation is that absence of P waves. And the second diagnostic point for atrial fibrillation on ECG is that the QRS complexes are irregular. What is irregular QRS complexes? Irregular QRS complexes, you can see that the RR interval between first two QRS complexes is 1, 2, 3, 4, 5, almost 5 small boxes. Let's see what is RR interval of the next QRS complexes. 1, 2, 3, 4, 5, 6. So here it was 5, now it's 6 again. It's almost 5, 5, 5. Here it's 1, 2, 3, 4, 5, 6, 7, 8. So you can see that there is absence of P wave, or P wave is absent, and the QRS complexes are irregular. So the criteria for the diagnosis of atrial fibrillation is met, which is absent P waves and irregular QRS complexes. So if a patient presents to you with palpitations, and on examination there is irregular pulse, and his ECG shows no P waves and irregular QRS complexes, then the diagnosis of atrial fibrillation will be made. Classification is atrial fibrillation can be acute, it can be chronic, it can be paroxysmal. Remember that if a patient who present to you with palpitations and you are suspecting atrial fibrillation, then the initial investigation that you will perform is a 12 lead ECG. But if you cannot diagnose atrial fibrillation on 12 lead ECG, even with a high suspicion of atrial fibrillation, then the next step would be to use a 24-hour ambulatory ECG monitor. This is a general rule for the diagnosis of any kind of arrhythmia. If a patient who present to you with palpitations and you are suspecting any kind of arrhythmia, then the initial investigation will be a 12 lead ECG, and the definitive If there you cannot make the diagnosis on 12 lead ECG, then you will use 24-hour ambulatory ECG. But if the diagnosis is made on the 12 lead ECG, then the next investigation will be echocardiogram and not a 24-hour ambulatory ECG monitor. So someone present to you with suspicion of arrhythmia, and you did a 12 lead ECG, and the arrhythmia is diagnosed on the 12 lead ECG, then the next investigation will be echocardiogram. And if the arrhythmia is not diagnosed on 12 lead ECG, then you will first do a 24-hour ambulatory ECG to diagnose the arrhythmia, and then after 24-hour ambulatory ECG, you will do echocardiography to see the cause of arrhythmia. So these were some points about the diagnosis of atrial fibrillation. The presentation, remember that in the clinical scenario, the hint towards atrial fibrillation is that if the patient present to you with palpitation, then on the ECG, you will try to look for atrial fibrillation, because in 1 minute, you cannot read an ECG from A to Z. Now, we all know that in atrial fibrillation, due to irregular heartbeat or due to turbulency in the blood flow, the chances of clot formation are very high. So in atrial fibrillation, blood clots can form in the ventricles. And those blood clots can travel through systemic circulation to different parts of the body, and which can result, if they travel to the brain, it will result in, if they travel through carotid artery into the brain, they will result in stroke. If they travel to mesenteric arteries, they will result in mesenteric ischemia. If they travel to limb arteries, they will result in acute limb ischemia. So if someone present to you with atrial fibrillation, he need to be anticoagulated to prevent this clot formation and further complication. Which patient are going to need anticoagulation and which patients are not going to need any anticoagulation, that will be decided on the basis of Chad's-Vasek score. Chad's-Vasek score, where C stands for congestive heart failure. So 1 point for congestive heart failure, H stands for hypertension, 1 point for hypertension. With A, there is 2. So if age is above or equal to 75 years, then we will give 2 points. And if age is below 75 year and above 65 year, then we will give 1 point. So for age, there is either 2 points or 1 point. If the age is 75 or above 75, then 2 points. Below 75, which is, you can simply say that if the age is between 65 to 74, then 1 point. D stands for diabetes, 1 point for diabetes, and S stand for, with S, 2 is written. 1S stand for stroke, so 2 points for stroke, ischemic attack. And VASIC, VAS, vascular disease, such as ischemic heart disease, peripheral arterial disease, for vascular disease. And the last one is S, which is stands for sex. If the female sex, then 1 point. So a person who present to you with atrial fibrillation, we are going to decide about anticoagulation. The score that we are going to use is Chadwick score, in which C stands for congestive heart failure, H for hypertension, A for age, 2 points for age if 75 or above, D for diabetes, S for stroke or transient ischemic attack, and VS for vascular, and S for sex. So if the Chadwick score is 0, no anticoagulation is required. If it's one in males, then we'll consider anticoagulation, and if it's one in females, then no treatment is required because one point in female is due to their gender. So one in female does not require any treatment, but if CHA-2DS score is one in males, then we will consider anticoagulation. And if the score is two or more, then we will offer anticoagulation. Which medication we can use for anticoagulation in atrial fibrillation? Remember that the first line drugs that are recommended by NICE are direct acting oral anticoagulants such as rivaroxaban, epaxaban. So our first line or first choice would always be direct acting oral anticoagulants. However, there is a contraindication of direct acting oral anticoagulants, and that is renal failure. In renal failure, these medications cannot be used. So we will use warfarin instead of direct acting oral anticoagulant if a patient is having a renal failure. So atrial fibrillation is diagnosed on ECG by absent E waves and irregular QRS complexes. And the need for anticoagulation is decided on the basis of CHA-2DS score. The CHA-2DS score of 0 require no treatment, and 1 in females also require no treatment. A score of 1 in males, we will consider anticoagulation, and a score of 2 or more than 2 will offer anticoagulation.